Welcome all. We're going to give everyone a few minutes to log in and then we'll get started with Dr. Carey and our seminar on overactive bladder. I'm Jen Rapaski from Medtronic. I work with the team at Central Ohio Urology to help manage their overactive bladder patients who use two of our 3 third-line therapies. Dr. Carey is one of the urologists at Central Ohio Urology who is an expert in overactive bladder patient care continuum. So he's going to talk to us tonight about what it looks like for a patient who's experiencing these symptoms. Dr. Carey comes to us with a lot of experience. He did his received his undergraduate degree at the University of Miami, went to the University of Toledo College of Medicine, did his general surgery and urology training at William Beaumont Hospital, and then did advanced fellowship training at the Cedars-Sinai Medical Center in Los Angeles. So he comes to us with a great deal of experience, and we're excited tonight to hear about what it looks like for patients at Central Ohio Urology to walk through the comprehensive care continuum that's offered to them in the practice. The process for patients who are experiencing some of the symptoms that we're going to talk about tonight start with changing lifestyle habits and move all the way through potentially trying medications. And if that's not successful, those patients move on to advanced third-line therapies that physicians at the practice like Dr. Carey offer to their patients. So with that being said, we'll go ahead and have Dr. Carey kick things off for us. If you have any questions during the seminar, feel free to put those into the chat or the Q&A and we'll address those at the end. Welcome, Dr. Carey.
Thanks, Jen. I appreciate the introduction. So I'm glad everybody could come out tonight and share a little bit of some of the excitement we have as far as things we can do to help patients with these problems. So I think it's about 5 after, so we'll kind of move on to the rest of the program. Throughout, if you have any questions, go ahead and drop them in the chat, and we'll have plenty of time at the end. We'll try to keep this interactive and go through the questions with you. So we'll move on to the rest of the program. So one of the greatest things about learning about what we can do for these problems is figuring out that you're not alone. These problems related to overactive bladder and loss of urine control are problems that a very large percentage of patients experience, and there's lots of people just like you that have these problems. And so one of the big misconceptions is that that this is supposed to happen as you age, that these are problems that you're just supposed to live with. And the reality is that losing urine control and having these bladder problems are not a part of normal aging, and the vast majority of the time we can dramatically improve your situation, if not resolve it completely. So what we wanted to go forward with is looking at how we can get you back, to that life without limits. And we're going to go through basically what happens to your bladder, what is the pathway for treatment of various different problems related to bladder control, and then what are some of the options that we have for therapy in making you better. We'll have, again, a lot of opportunities for Q&A at the end, so please keep submitting any questions you may have. Again, this is a super common problem. Overactive bladder is something that happens in anywhere from estimates of 30 to 40 million people in the United States alone. So that's a huge number. This can happen to people of all ages. It can begin in your teens or 20s, does tend to progress as we get older. But just because it's more common as we age doesn't mean that it's normal. It just happens more often as we age. So again, you're not alone. Compared to very common problems like diabetes, overactive bladder even exceeds those problems. So what is normal? Overactive bladder is defined, it's a syndrome of symptoms, and we like to think that 8 times in a day is a normal amount of heading to the bathroom. and waking approximately 2 times per night. If you break those numbers and are going more frequently than that, or waking up more than twice a night, then that's a sign that you may have this symptom or syndrome of symptoms known as overactive bladder. It can be associated with urgency. That's sort of the hallmark symptom of overactive bladder, that sense of not being able to delay getting to the restroom in time. And that can even result in accidents where you get an urge to go and can't make it fast enough, that we call urge leakage. So how does this all happen? The bladder is controlled essentially by your brain. Your brain acts largely to apply the brakes onto your bladder. So there can be many different levels of how things interact. The brain is involved in, like I said, applying those brakes. So sometimes patients, if they have a brain injury, such as a stroke or other problems, such as multiple sclerosis or Parkinson's disease, may have their bladder begin to become more overactive and have urge incontinence problems. Other times, it's just simply because as we age, there are changes to the bladder muscle cells and to the nerves to the bladder that result in it sending you bad information. Essentially, what the bladder is doing is it's sending you to the bathroom when it really hasn't reached a full capacity. So a lot of patients with overactive bladder will say, I feel like I'm not emptying my bladder well because I'm going in there every 30 minutes and really not much comes out. And a lot of times that symptom is, consistent with an overactive bladder that is just sending you bad information when it's not really full. So when the person goes in there, they go to the bathroom, nothing much happens. And that's part of the pathology of overactive bladder, is that bad information, that bad signaling from the nerves of the bladder that causes it to behave like it shouldn't. So there are, a number of things that can, promote the development of overactive bladder. Simply getting older is one of them. But there are also lots of behavioral things that we're going to dig into, as well as, potential pelvic floor changes that can occur, during pregnancy. We're going to look at 3 of the very common bladder problems that we experience: stress urinary incontinence, urinary retention, or the difficulty in emptying of the bladder, and then overactive bladder, like we've already mentioned. So stress incontinence, this is something that's a very common problem as well. Stress urinary incontinence is the loss of urine control that occurs usually with a physical change. So coughing, sneezing, laughing, lifting, jumping, exercise. So that's sort of the definition of stress incontinence. As opposed to overactive bladder associated leakage, usually stress urinary incontinence leakage is a small volume accident. It occurs, directly with that physical activity: jumping, coughing, sneezing, getting on the trampoline with your kids, lifting things. Those are typical stress incontinence problems, and it's more of a physical problem as opposed to overactive bladder, which is more of a functional problem. Urinary retention is the inability to empty the bladder. This problem can be a little bit more complicated. There can be many reasons why a bladder may not function properly to empty. But the good news is that we have some means with the use of some of these therapies to help resolve that problem if it does occur. And then finally, overactive bladder, like we talked about. Obviously, the patients that have this problem are bathroom mapping, we call it. They know where every single bathroom is in their life. They know where the bathroom is in Kroger. They know where it is all around town, because they have to find them very frequently. And then when it's COVID, you can't get into one. So that's also a problem. They oftentimes are wearing pads for protection, which is, impacting their quality of life. And the condition can also impact their ability to, get through a meeting, to get through a movie, to sleep through the night. So all these things have a huge impact on their quality of life. So some people always ask me, how in the world did you get involved in this incontinence bladder control business? And the reason is that because these people are so miserable, if you can truly help them, which we often do, the appreciation level is very high. So it's exciting stuff. So the good news, like I was talking about, is that we really can help most of the time. We begin by, identifying what the problem is, and then we'll walk through sort of the pathway from lifestyle changes to potential medication trials, and then some of the advanced therapies for patients that either, don't respond to the basic things of lifestyle changes or medications, or perhaps, have side effects to those treatments. Lifestyle changes are huge with overactive bladder. The biggest thing out there is caffeine. So caffeine is a drug like any other. It just comes in your coffee, your cappuccino, your tea, your dark chocolate. And it is the world's largest bladder irritant. So we oftentimes will spend some time going over with patients we call a voiding diary, looking at what kind of fluids they may be taking in, or what type of caffeine intake do they have, and working on getting rid of some of those bladder irritants. The other things that we do are try to ask them to timed urinate, not to wait too long. The bladder, if you have an overactive bladder, is going to reach a certain filling point, and then it's going to start sending that bad information. It's going to make you have to rush to the bathroom, or even cause the bladder to spasm that results in an accident. So beating it to the punch, emptying out the bladder before it gets too full, can decrease the number of urge events you might have and the number of accidents you may have. The slide mentions bladder retraining or biofeedback. Biofeedback is just a mechanism to help you understand how to exercise the pelvic muscles, and we work with a lot of women's health physical therapists who will teach patients how to do those exercises very well. They also do some passive pelvic floor electrical stimulation, which can calm down the bladder. Biofeedback and pelvic muscle bladder training with a women's health physical therapist is more often utilized in patients that have the stress incontinence, the problem that needs more support because of having children or other issues. So those patients with stress incontinence are more likely to get more results from working with someone to do biofeedback training than is an overactive bladder patient. Medications are sort of the next step in managing overactive bladder. The underlying changes to the bladder itself and to the nerves, once you have them, are permanent. They're not going to go away unless you do something to alter how they behave. So medications are one way to do that, and the medications work to essentially calm the nerve transmission between the nerves and the bladder itself. Medications can be very helpful. They do have their drawbacks of side effects. Most of the medications for overactive bladder have side effects of dry mouth, constipation, those types of problems. There is one medication that's newer that it doesn't have those typical dry mouth, dry eyes, constipation type side effects, but it can cause some problems with blood pressure control in patients that are on a number of medications. Some of the issues with that new medication called Myrbetriq, you may have seen commercials for this on TV, is that because it is new, the coverage for that medication sometimes can be limited. So it does have that as a possible limitation. So between the combinations of potential side effects or lack of effectiveness, in a survey of patients that have these problems, a good percentage of patients, this says 72%, aren't able to maintain those medications or don't stay on them. And if you aren't on them, then your problems will regress back to the symptoms that you had at the beginning. So for patients either that have not responded to behavioral changes of decreasing caffeine, of timed urinating, of moderating their fluids, or of the medication trials, we have a number of advanced therapies that can be helpful for those patients that we consider a refractory patient, meaning someone that hasn't responded to the basic things that we do. So we're going to review some of those, the pluses and minuses of each of those. And again, if you guys are having questions as you're watching, feel free to submit those questions and we'll go over them at the end as well. The first advanced therapy we're going to review is the use of injected medications. So everyone's heard of Botox. Botox is the medicine that is administered in the bladder. Botox has uses all throughout the body to help relax spastic muscles. So in overactive bladder, the pathology, part of that pathology is that spastic bladder that's causing those contractions that result in an accident. So we've been using Botox for a number of years now, close to 10 years of injections of Botox into the bladder. The pluses and minuses of Botox are that it can work where medications may have failed. It is an office procedure, so it's done in the office with a local numbing wash of the bladder. Now that's for our female patients. For our male patients, it usually does require an anesthetic because of the nature of how it's administered. On average, about 2 times per year, Botox has to be given because Botox always wears off. The amounts that we give in the bladder are very low, so there really have not been any around the body side effects related to Botox administration in the bladder. Sometimes you may see a commercial for Botox and they'll list a number of potentially scary complications, but whenever they put out a commercial, they have to list all of the possible complications that might be seen in all of the applications of that medicine. So with bladder Botox, the doses are very low, and we don't see systemic around the body side effects typically. We do sometimes see that it may work too well. So approximately 5% patients may have the Botox work so well that their bladder doesn't empty properly. And in that case, they may need a short-term use of a catheter. So to me, those are sort of the pluses and minuses of it. It can work where other things have failed and can be highly effective. It does require repeat treatment, so you're going to have to continue to administer the Botox on average about 2 times per year. And there is that rare possibility that it may have difficulty with emptying your bladder. The continuance of Botox, people continuing to use it, is variable. This mentions 51% stop after 2 treatments. I haven't quite seen that number in my practice, but there is with those potential need for ongoing treatment, those are some of the limitations that we see, and that can impact people's willingness to continue to do that procedure over and over again. So the next topic is looking at what we call neuromodulation. So we mentioned in the beginning that the nerves of the bladder are part of the problem. A big part of the problem is that the bad information is being sent to the bladder, and that bad information results in the frequent trips to the bathroom, the waking at night, the feeling of urgency and not being able to get to the bathroom in time. And so there's a couple of different mechanisms to help to calm those nerves to the bladder, to provide what we call sort of an electrical interference to make those bladder nerves behave better. The first one of those is what we call posterior tibial neuromodulation, or Ptnm. So that's a big old bunch of words, but basically what it means is that, believe it or not, the nerve that runs down by your ankle, if I could actually make my leg go up on the table, I could show you where we do this, but there's a little slide coming up that'll do that. But basically we stimulate that nerve behind the ankle, and that nerve runs up into your pelvis, interacts with the nerves to your bladder, and when you stimulate that nerve by the ankle, it actually results in calming of the nerves to the bladder. There have been some very well-designed studies that looked at how this works, and they had patients involved in those studies that thought they were getting the nerve stimulated, but really weren't, and those patients really didn't get better. But those that you actually do stimulate that nerve, they do get better. And compared to medications, the use of Ptnm or neuro treatment, it's called, get just as good of results as they do compared to medications in some of those clinical trials. So this just kind of shows the setup for posterior tibial neuromodulation, or the neurosystem. Essentially, you stimulate the nerve behind the ankle, the posterior tibial nerve. You'll feel that sensation of stimulation down sort of in the ball of your foot, and it acts to calm that exaggerated nerve response that's driving the symptoms. Helps to act as electrical interference to calm the bladder. The pluses and minuses of this therapy are, yes, it can absolutely work, and we have lots of patients that are successful using it, particularly if they don't want to take medications for their problem. They don't want to deal with the side effects or the cost of the medications. They'd like to do something as an alternative. this can be highly effective. It does take some time commitment. So it requires a period of sort of training the nerve. So you have to stimulate the nerve weekly for a course of approximately 10 to 12 weeks. And then somewhere in the middle of that course, usually around 6 weeks, we assess, how you're doing. And if you feel as a patient that you're getting the results that you'd like and it's improving the quality of your life and your bladder symptoms, then we continue and finish that startup phase. After you get through that, you move to a maintenance sessions where those are done approximately every month, sometimes every 2 months. But it really just depends on, kind of what your bladder and your situation needs. But on average, it's typically, monthly. It's like all overactive bladder treatments, it has to be maintained and continued, or you kind of go back to those baseline symptoms. So that's how posterior tibial neuromodulation or neuro works. So the last group of what we call neuromodulation therapies include the Interstim system. So the Interstim is a sacral nerve stimulator. So it stimulates the nerves that supply the pelvic floor and bladder. The nice thing about Interstem therapy is that it has a long track record of being around since 1997. I was involved in some of those original trials back in 1997 up at Beaumont Hospital with Ken Peters and a guy named Ananias Diokno, both doctors that were involved in some of the early development of this technology. So the beautiful thing about Interstim is that you get to try it before you buy it, so to speak. It's a test trial therapy where you undergo a test run to see if you like what it does for your bladder. And during that test trial, we stimulate those nerves, and then you monitor, how you do with regard to control of your symptoms. And then you're judge and jury about whether you think it's been adequately helpful to you. And if you feel that it significantly improved your quality of life, then we go ahead and place the device under the skin. The device has, a generator that goes underneath the skin. Previously, there was only one choice, but now there's a rechargeable version, which is about the size of a half of a stick of a standard chewing gum, and a non-rechargeable version that's about the size of a poker chip. So these go into your backside, essentially about where your back pocket would be. And the rechargeable version requires that you continue to recharge it intermittently through your skin with a recharging pad. And that battery can last approximately 15 years. And the non-rechargeable version, can last on average anywhere from 3 to 6 years. So essentially, when you're considering, the Interstim system and its help to you, usually you've kind of gone through the steps of finding out what's happening, going through an evaluation, trying some of the basic things, behavioral changes, medication trials. And then if those aren't being successful, then you consider doing a test trial. And you go through that test trial. And like I mentioned before, you're sort of judge and jury about whether you feel it's been helpful. And then we monitor your symptoms during that test trial. And if you reach, appropriate milestones and you feel encouraged by what's happening, then we go ahead and place the device under your skin at the next step. All of that's done usually with sedation, just snoring medicine, anesthetic, kind of like you'd have for a colonoscopy, and then some local anesthetic. Sometimes patients can do that just in the office with just local anesthetic. In my personal practice, I usually give patients some sedation. I just find that it's easier for them and more comfortable. It's a very brief procedure to place the test leads in position. They're just placed simply through a needle stick. So there isn't any incision or cut made. And then you wear around that temporary externalized device that mimics what the real device does, and then monitor what you get out of it as far as your symptom control. And then kind of go forward from there based on a conversation, with your physician about whether it's been successful. So like I mentioned before, Interstim's been around a long time, several 100,000 implants worldwide. There have not been any problems as far as any injuries associated with Interstim therapy. It's an incredibly safe procedure. the satisfaction is high compared to typical things like medications. 84% of patients report, satisfaction when using Interstim therapy, 3 times greater improvement in quality of life compared to medications. And then, looking at, their success compared to medications, 76% indicate they achieve success compared to the use of medications. So certainly a viable and a very reasonable and safe option for anyone that is struggling with the significant impact of these symptoms to their quality of life and wants to pursue, another option. So, looking at whether this is something that you might consider, like I mentioned, it's sort of, after you've gone through the initial steps, have you been struggling? Have you not responded to maybe a medication that your primary care physician placed you on, or have you not responded to decreasing caffeine? Are you having side effects with the medications? If you can answer yes to those questions, then you might be someone who is an appropriate candidate to consider this test drive of this type of therapy to see if it's right for you. So we've got a little video that goes over Sarah and her story about what she experienced with Interstim therapy. So we're going to go ahead and play that for you so that you can hear someone's personal account of how they interacted with this therapy. And then after we're completed with that, we'll have plenty of chances to go through all of the submitted questions through the chat. And if while you're watching it, you want to submit some other ones, we'll be happy to answer all of those at the completion of this short video.
My name is Sarah, and I'm a management consultant, and I'm 28 years old.
Good morning, Sarah. You have some missed calls.
It's a lot of work, and I'm very much engaged in my career and where I'm going, and it's just very exciting right now. When I was about 17, I started noticing more frequency and the urgency coming on, and dealt with it through various forms of antibiotics and just different approaches with diet. And then it got worse and worse. I was really embarrassed when I first joined this company that I had this to deal with, and I actually called it Bladderitis. I would get into work and attend a meeting and again be fine sitting down the minute that you stand up. Kind of embarrassing when you've got clients around and you've got to hightail it to the ladies' room. You just always felt like you had to go. This just was not good. It was horrible. So how I was led up to Interstem was through a physician referral that this was the last hope, basically, that I had. And I went in very skeptical, very reluctant, and very closed to this final idea.
The thing I remember most about Sarah is when she came to see me, she was miserable, first of all. She had tried numerous therapies. Everywhere she went, she was being ruled by her bladder symptoms and was controlling her. It was affecting her relationships. She is a professional who travels a lot. It was affecting her work. And when I saw her, she was essentially at the end of her rope. The best thing with Sarah that I remember is when I talked to her about the Interstim, she was so skeptical.
I didn't understand why she was so sure that it would work, but given the high percentage rate, I was very open towards the end of our conversation. Given that there was a trial, I was very secure with the fact that it wasn't going to be permanent, that we could have that trial period. My test stimulation period was interesting. It involved a lot of different changes to my settings to try to figure out which one was going to work, and nothing seemed to be doing the trick until the day before the end of my trial, which was a great success for me because it took a little bit of time to settle in. So after the success of the trial, I decided to go ahead and have the second surgery for the implant, and have had no problem since. I love to run and was only really able to run short distances. Any movement to the bladder was just, would set you off with regards to feeling like you had to go to the bathroom. after Interstem, it's like I never had that problem before. I can stay at the gym as long as I want. And I even ran a half marathon just because I didn't have to deal with that anymore. I think of all of the things, I am the most proud of that moment. 2 hours and 28 minutes and 13.1 miles in 20-degree weather. You know, I did it because of Interstem. I don't think I could have done it without it.
So sort of Sarah's story does mimic what we see with a lot of patients. And like I mentioned in the beginning, you know, one of the most exciting things about what I do is the ability to impact people's quality of life. And I think the biggest message from this is that there are so many options for you. There's no reason to continue to suffer with these symptoms. If you have them, we have you know, a very wide variety of potential options that we can help walk you through. And there are a number of physicians in our group that are involved with these type of therapies. Myself, Dr. Jonathan Corbett, Dr. Linda Osborne, Dr. Mike Cunningham, and we also have a phenomenal resource in Liz Millirons, who is our nurse navigator, who helps, you know, patients sort of walk through the various options, because they sometimes can be a little dizzying about, you know, what are the pluses and minuses. And she's a essentially free and available resource for patients to get their questions answered and help them, you know, move along through treatment to find the one that works best for them. So I think that pretty much concludes, you know, everything we were going to talk about today. I think Jen is going to move to kind of go through some of the chat questions, and we'll certainly go through those and then wrap things up from there. So thanks again for everybody for coming out to the webinar tonight, and please feel free to reach out to us. There's a number on the screen there that you can call with questions, and if you want to pursue any further evaluation or treatment, we're available for you. So Jen, what do you have for us?
Okay, Dr. Carey, the first question.
Bladderfest.
Bladderfest 2021.
Yes.
Prone to urge incontinence, is it better to urinate often to keep the bladder not full, or better to work on increasing the capacity of the bladder by retaining as much urine as possible when you're near a bathroom?
Yeah, that's a great question. Yes, people talk about the concept of bladder training. I really haven't found that it has been very helpful to try to push your bladder, you know, beyond, to try to, you know, control that those urges, because they are, you know, really something that are out of your conscious control. So I really would recommend that patients go by the clock and not wait for their urge. That trying to, you know, push your bladder to hold more oftentimes just results in more urge-associated accidents. Now, there are some things you can do from the standpoint of pelvic muscle rehab. We talked about working with the women's health physical therapist. If you can learn how to do a good pelvic muscle contraction, if you get an urge to go, you can learn how to do what we call quick flicks. Essentially, these are just fast, quick contractions of your pelvic floor muscles. And when you quickly contract your pelvic floor muscles, it sends a negative message back to your bladder to not spasm, to stop trying to contract. And so that can be a helpful way to sort of train your bladder. But really what you're doing is training your pelvic floor muscles how to contract well, and then using that to sort of shut down an urge event. But I really don't, I have not felt that, there's a lot of utility in trying to push your bladder or do what we call bladder training. I just don't think it really helps that much in my experience. It's better to go by the clock and beat it to the punch and empty it out before it gets to that point where it's going to spasm and cause an accident.
Okay, next question. For any drugs, what are the side effects?
Yeah, so there's 8 or 9 drugs out there available for overactive bladder. The vast majority of them fall into a category of drugs we call antimuscarinics or anticholinergics, which are the type of receptors that are found on the bladder. And it turns out that those receptors are found, scattered throughout the body as well. So when those medications, bind those receptors on the bladder to help calm it down, they also bind those receptors where they're distributed, throughout the body. So those, 8 of, say, the 9 medications that are out there fall into that anti-muscarinic, anticholinergic type of a medication, and they all have those typical side effects of dry mouth, dry eyes, constipation, and those are because those receptors are found on your tear ducts. So when they bind those, it decreases your tear production. They're found in your salivary glands. So when it binds those, it decreases your saliva production. They're found on your colon. So when it binds those, it slows down your colon, and that leads to the side effects. Not everybody has side effects. Some patients are amazing with medications, so you don't have to feel like medications are not a possibility, because some people do fantastic with them. They don't have any side effects, and they use them forever. So those are the typical side effects with those anti-muscarinic, anticholinergic medicines. That one new drug called Myrbetriq or Myrbetriq is a different type of medicine called a beta agonist, and it doesn't have those typical dry mouth, dry eyes, constipation type side effects. It can sometimes increase your blood pressure. Not in an average patient who doesn't have a blood pressure problem, not typically in a patient who takes one medication for blood pressure, but usually in somebody that has a significant problem controlling their blood pressure and needs multiple medications. In those patients, we usually aren't even going to offer that drug. But if you have, take one medication for high blood pressure, you certainly can try or consider Myrbetriq or Myrbetriq, and then just, follow up to monitor your blood pressure control. But in clinical trials, there really hasn't been much impact to those patients that have well-controlled blood pressure on, say, one medication. They usually are going to do just fine with that medicine, Myrbetriq or Myrbetriq.
Okay, is OAB more prevalent in women than in men, and if so, why?
That's a great question. If you look at statistics, it looks like overactive bladder is about 50-50 in men and women as we age. The male side gets a little bit complicated by the prostatic growth. So prostatic growth, by blocking the exit of the bladder and making it more difficult to empty your bladder because the prostate begins to get in the way, can cause overactive bladder symptoms. If the bladder is obstructed or blocked, one of the ways it responds is to have symptoms of urgency. So it's actually pretty equal numbers of men and women as we age develop overactive bladder symptoms. So the male side is just complicated with more of a potential for having the exit of the bladder blocked by that growing prostate. So a lot of times with men, we may focus our attention first on decreasing the resistance from the prostate by using medications or other treatments to open up the prostate. And then if the patient doesn't respond to that, then we would add in the typical list of overactive bladder therapies that we've already talked about, including the standard behavioral things like getting rid of caffeine and then medication trials, and on from there to advanced therapies if those don't work.
Okay, with a 75% rejection rate on drugs and 50% rejection rate on Botox, why can't patients go to Interstim therapy sooner rather than later?
They can go to Interstim whenever they've gotten through the typical startup treatments. And one of the issues that you have to one of the barriers, I guess, you have to hurdle is insurance coverage. So they consider these advanced therapies. So they're going to want you to show that the person has undergone a typical pathway of steps to treatment. So behavioral changes first, medication trials after that. So really, we found that from clinical trials that if you have gone through 2 medication trials, that your statistical chance of responding to any additional medication trials is exceedingly low. So if you're someone who has gone through a medication trial or 2 and you haven't gotten relief, then you're typically a candidate at that point, both from being an appropriate candidate to move forward, as well as from a coverage standpoint with your insurance companies. But we have to, document that the person has gone through those typical steps. You don't have to, say, fail Botox to go on to Interstim therapy. Botox and Interstim are considered sort of on that even plane after failure of medications. There aren't too many insurance providers that will allow patients to advance to Botox therapy or to sacral nerve stimulation, the Interstim system, before they've tried and failed a couple of medications. So that usually is part of the pathway. You can jump ahead with tibial nerve stimulation. So with the tibial nerve neuromodulation, that can be done almost as first-line therapy after behavioral changes. So you don't necessarily have to fail medications to do tibial nerve stimulation. Most of that's usually covered as sort of second-line therapy after behavioral changes.
Okay. How do you know if a therapy's working?
Specifically any one particular therapy, or what is the?
It doesn't mention, it just asks if therapy's working.
Yeah, so,
So
it's,
potentially,
if they're referring to an
Sorry, go
Interstim
ahead.
trial, then, it would be, you're basically looking for the patient to be happy. To me, that's the bottom line. Do they feel like they're doing better than they've done on any prior therapy? So those are the easy, targets of what you're kind of looking for. You want them to be excited about the results that they've achieved. You want them to feel that they've done better on this therapy than they've done on anything else. Will it make you 18 years old again? Maybe not. I mean, you may still have some persistent symptoms, but the person who's undergoing the test, should have, we can feel at least a 50% improvement in their most bothersome symptom, whether that be frequent trips to the bathroom or urge-associated accidents. But that's more almost like to me, that's an insurance definition. They have to meet that criteria to go forward with the placement of the real device. But to me, the real test is, is the person excited about it? Do they feel like this has really made a difference for them? And if that's the case, then usually they've already met that 50% number. But those are some of the things, the benchmarks that we have to achieve from an insurance standpoint. But really, we just want the patient to be excited about the therapy, about the improvement in their quality of life, and desiring to proceed to go forward.
Thank you. If you have symptoms of overactive bladder, will they progressively get worse over time? And which therapy provides the best outcome in the long term?
They don't always necessarily get worse over time. Everybody's situation is different. So you may be someone that, all you have to do is get rid of caffeine in your life, and the underlying symptoms will get to a level where you're happy, and then we're happy. If you do those things and you haven't improved, then, we step up to add a medication trial. And you may be someone who tolerates medicines and, does extremely well with them, have zero side effects, perfect effectiveness. You can stay on that medicine for the rest of your life. So some patients, don't do that though. So if you've gotten through a medication trial or two and you're moving on to the next steps, then it's just a conversation about what makes sense to you. So I just kind of talk to patients about, the options, the pluses and minuses, just kind of how we reviewed them, in the presentation today about, Botox injections versus a test trial of neuromodulation, or even doing tibial neuromodulation. And, some of those factors that we talked about earlier make a difference. If you're 25 years old in a busy job, you're probably not going to come in once a week to do tibial nerve stimulation. If you are retired and your schedule isn't jam-packed, then maybe that makes sense. And so they may choose that a little bit more often. And then, some patients, even though the chance of not emptying their bladder is small, at 5%, they still may not want any part of the possibility of potentially needing to drain their bladder with a catheter while the Botox wears off. To me, there's not one perfect therapy for long term. It just kind of depends on how each person wants to go about it. And the good news is you have lots of options, so we can help you through whichever one makes the most sense to you.
Very good. How good is the coverage for Myrbetriq?
In my personal experience, it hasn't been super great. I mean, they have some programs of coupons and so forth that may bring it back to equivalent to some generics in some plans. But it hasn't been, it has been a little bit of a challenge. So we like to look at the person's individual plan when we give them a medication. I don't, if I'm going to give you the medication and it turns out that it's so expensive that you can't afford it anyway, or don't want to afford it anyway, then it's kind of like the, a golden egg you can't have. We try to look at that up front to make sure that it's not going to be incredibly expensive for them from the beginning. If it looks like they've got good coverage, then we'll offer that medication to them. If it doesn't look like that they have good coverage and it's going to be really expensive anyway, then that's typically not a step that you want to put them through, because it just becomes frustrating when they find out it's super expensive.
Okay. Is decaf tea better than decaf soda?
Decaf in general is good, better. If you drink enough decaf anything, you're probably going to get some caffeine because it's not perfectly decaffeinated. So decaf soda with the carbonation, sometimes, carbonation is irritating to the bladder for whatever reason. So, probably I would say decaf tea is probably going to be a little bit better as far as you're going to eliminate that carbonation part of it. But really, you just want anything that doesn't have caffeine, being that it's the stimulant of your bladder. It's just going to be like, I always say, it's like gasoline on the bonfire of overactive bladder. It just doesn't help.
Okay. Would these therapies help with not getting UTIs?
In general, I would say no, unless the person has a problem with emptying their bladder. So we kind of touched on urinary retention. So if someone doesn't empty their bladder completely, there's kind of two main things that can be happening. One is they've got some kind of a blockage in the plumbing. So, we're the people plumbers as urologists, so we can help unblock those plumbing problems. Or they might have a problem where their bladder doesn't empty that isn't because of a blockage. We call that non-obstructive urinary retention, where there's no blockage involved. In those cases, if they're not emptying their bladder well, not emptying your bladder is one of the risk factors for developing recurring urinary tract infections. So Interstim Therapy, one of its indications is for non-obstructive urinary retention, meaning there's not a blockage. It's just that the bladder's not behaving properly to empty it. So in those patients, they either need some form of catheterization to empty their bladder, or they can pursue, a test trial of sacral nerve stimulation. And during that test trial, we monitor their bladder emptying. And a lot of those patients can completely get away from the need for a catheter, which is pretty amazing. So the exact mechanism of how that works is a little bit mysterious, but it does work. And so if you're someone who has a non-obstructive retention, you can't empty your bladder and you need a catheter to do so, then a test trial of sacral nerve stimulation is a very safe, easy thing to try. And so if it works for you, amazing. We can go forward and get you free from catheters. So in that case, yeah, it could help you, get rid of recurring infections. Otherwise, I would say no. So if there's not a retention problem, then these things really don't have any benefit for helping recurring urinary tract infections.
Okay. Does insurance cover Ptnm?
Yes, it does. All insurances typically do. Medicare, all the private insurance providers, yes, they do.
Okay. Does Medicare pay for this and Medicare supplement covered? Not specific to any therapy on this question.
I'm not sure. I mean, Medicare is like, Medicare covers all these therapies that we talked about. So they've been around for a while. Interstim since 1997, Botox about 10 years, Ptnm about the same time as Botox. So they're all covered, but whether supplementals pick up the difference, I can't tell you that. That part of things, that's too many things that I can't keep track of. I try to take care of bladders. But we got a business office that could help you understand that and what your out-of-pocket costs might be. So that they can help you work through that. But they are all covered. It's just a matter of whether Medicare is always 80%, and then there's 20% that's not covered. So you have to get that part maybe sometimes covered by your supplemental. I'm not sure about that, but we could get that question answered for you. I just can't do it.
Rolling that ball onto someone else.
Yeah.
What sort of stimulation is applied to the sacral nerve?
What was the question again?
What kind of stimulation is applied to the sacral nerve?
Well, it's electrical stimulation. So it's a very low energy stimulation to the sacral nerve, just like you do for the tibial nerve. The patients feel in the background kind of a tapping or buzzing sensation, usually where they would sit on a bicycle seat area or around the bladder. In men, maybe around the scrotum or that area. In the women, they may feel it in the vaginal space, around the rectum. All of it's kind of in the background. Usually what happens during this therapy is initially you may feel that sort of background tapping or buzzing sensation, but your brain, like it does with all things repetitive, compartmentalizes that and puts it in the background. So patients oftentimes don't feel any stimulation at all while their device is working in the background.
Okay, so that's all for the questions that we have. Any last minute questions?
Well, good. Well, thanks everybody again for coming out. I think that, Jen, you're going to rebroadcast this or leave it available potentially if people want to watch again. Is that right?
We are. So if you look up on the screen, the number that's on the screen is specific to answering questions. So Liz, who Dr. Carey referred to earlier, she's a great resource to the practice. She's very clinically educated in all of these therapies, therapy options for patients. And so Liz will be answering the questions and forwarding them appropriately if you have any after the seminar. If you'd like to make an appointment to come in and see a provider, then you can do that through that number with Liz as well. So we wanted to thank you for your time tonight. Thank you for, taking time out of your evening, and Dr. Carey and Liz and the team is always available to answer questions, as well as if you have any questions about the Medtronic therapies, you can go to the Medtronic website for the Interstim Therapy and the Ptnm. You can find more specific information from a therapy standpoint there. So thank you all for joining us tonight.
Thanks, Jen. Have a good night, everybody.
Dr. Carey.